This will be a self-guided module covering chest tube basics. You will be asked as you proceed through this module to press pause when there's material you need to review, and then to press play again when you're ready to continue. This should take no more than 15 minutes to review the basics of chest tubes. Let's start by reviewing a respiratory assessment. This includes monitoring the O2 saturation, the heart rate and rhythm, breath sounds, observing for use of accessory muscles, and assessing for pain and treating if pain is reported. Per the pain management policy, you'll assess the location, quality, characteristics, intensity, and what makes the pain better or worse. Notice there are multiple pain scales depending on the condition of the patient. If a patient does report pain, monitor and document pain management and interventions. Reassess the pain after interventions as appropriate. Pain, per the pain management policy, is reassessed a maximum of 90 minutes following each PRN pain management intervention. The PRN pain management response should be documented in CareConnect.
What's wrong with these pictures? The lungs are not equally inflated, and the air or fluid in the pleural space is compressing the lungs. With the decreased ability to inflate the lungs, there's a decreased ability to breathe, and therefore a decreased ability to provide oxygen to the body. You may see both air and fluid, or an empyema, which means pus or infection in the pleural space. The goal of a chest tube is to remove the air, blood, or fluid that is interfering with full lung expansion. The way that's done is via a chest tube inserted into the pleural space. The gray is the clamp holding the tissue open, and the purple is a chest tube.
Once the chest tube is sutured in place, it is connected to the chest tube drainage system as shown. Pause this video and locate where the chest tube drainage system and chest tube are connected. Now that you've located where the chest tube and chest drainage system connect, let's locate the parts of the chest tube drainage system itself. In a moment, you will pause this video and locate the air leak monitor, suction monitor bellows, suction control regulator, positive pressure relief valve, suction port, manual high negativity vent, and the chest drain connector. Pause this video and locate each identified part of the chest tube, including the collection chamber. Is this vigorous bubbling in the air leak monitor chamber good or bad? Bubbles are considered bad. What that means is there's an air leak somewhere in the system, meaning either in one of the connections or in the chest tube drainage system itself. Wait, how did the water get in there? Let's talk about chest drainage system setup.
Wrapped unit from the sterile outer bag. Carefully open the CSR wrap using sterile technique and only enter the chest drain into the sterile field. Each unit comes equipped with a large, easy-to-grip handle that makes handoff and patient transport safe and easy. The sturdy swing-out floor stand should be open for setup convenience and for placement onto the floor. To begin, fill the water seal to the 2 centimeter line with the 45 milliliters of pre-packaged sterile water provided with each drain. Simply remove the pre-packaged sterile water ampule from the back of the drain, twist off the top of the ampule, and insert the tip of the water ampule into the suction port. Empty its entire contents by squeezing the ampule until all of the water empties into the drain and fills the water seal to the indicated fill line. Discard the ampule. Next, connect the chest drain to the patient by inserting the patient tube connector directly into the thoracic catheter. The patient is now on gravity drainage or to water seal. To apply suction when prescribed by a physician, connect the suction source vacuum line directly to the chest drain suction port located on the top of the drain. Turn the suction source on and increase the vacuum to -80 millimeters of mercury or higher. A suction monitor bellows provided on the Oasis offers visual indication of sufficient operating vacuum levels for best performance. The suction monitor bellows must be expanded to the delta mark where indicated or beyond for a standard -20 centimeters of water or higher regulator setting. Visual expansion of the bellows across the suction window will confirm adequate suction operation. The Oasis suction regulator is preset to a -20 centimeters of water suction pressure level directly out of the package. Suction pressure can be adjusted to any desired pressure level between -10 centimeters of water and up to a maximum suction pressure of -40 centimeters of water. Changing the regulator suction control setting is easily done by adjusting the rotary suction control dial located on the side of the drain. Simply dial down to lower the suction pressure setting and dial up to increase the suction pressure setting. When changing from a higher to a lower level, use the manual high negativity vent located on top of the chest drain after regulator adjustment to reduce excess vacuum down to the lower prescribed level. As with any chest drainage system, the drain must be placed below and kept below the level of the patient's chest in an upright position to maximize drainage efficiency. We recommend hanging the unit bedside using the multi-position hangers provided. The integrated flexi hangers accommodate today's newer bed designs and allow single hand placement and transport.
Assess the dressing to make sure it is dry and occlusive. Inspect the skin for signs and symptoms of infection and palpate the surrounding skin to identify subcutaneous emphysema. Remove any dependent loops from the tubing by looping it on the bed or chair. This allows gravity drainage and prevents pressure from building up in the pleural space. Next, assess the quantity and quality of fluid in the collection chamber. Clearly mark the level of the fluid and mark the date and time. Next, assess for an air leak by looking for bubbling in the water seal chamber. Bubbling indicates there is an air leak somewhere in the system. It could be at the patient insertion site, in the tubing or tubing connections, or a crack in the chest drain itself. The graduated markings help to quantify the size of the air leak from 1 at the lowest to 5 at the highest. Bubbling may be continuous or intermittent. If it's a new air leak, you need to identify the source of the air leak and fix it if possible. To locate the air leak, briefly clamp the chest tube at the dressing. If the bubbling stops, you know the air leak is either at the insertion site or in the lung itself. If bubbling continues, briefly clamp the tube just distal to the first tubing connection. If bubbling stops, you know the air leak is in this connection. Try to seal it by reinforcing the connection. If bubbling continues, move down the tubing and clamp about every 12 inches or so to identify the source of the air leak. If you get all the way to the drain itself and clamp and still have bubbling, you know the air leak is in the chest drain itself. You'll need to go ahead and switch out the chest drain. Keep in mind in this whole process when searching for the air leak, never clamp the tubing for more than a couple of seconds or you risk a tension pneumothorax. Next, check for titling. Titling is the up and down movement of the patient pressure float ball in the graduated water seal chamber. With inhalation, negative pressure increases and the float moves up. And with exhalation, positive pressure pushes the float back down. With positive pressure ventilation, titling will be just the opposite, and this is normal. You typically will not see titling with an air leak. Other reasons for no titling include a tubing occlusion, the lung is fully expanded, or PEEP, which can dampen oscillation. Titling is more apparent when suction is turned off. Finally, ensure that the drain's dry suction regulator is set to the right setting and that the orange suction monitor bellows is expanded to the triangle mark. If the bellows is not expanded, check that your suction tubing is connected and not obstructed. Ensure that the wall suction regulator is on and turned up enough to expand the bellows. If the order prescribes water seal, you will disconnect the wall suction from the suction port of the drain. The orange suction bellows will no longer be expanded. If the chest drain is full or has a crack in it, you will need to replace it. Make sure you have the new chest drain open and ready for connection before clamping and disconnecting the old chest drain. To switch the drains, clamp the blue patient tube clamp and disconnect the inline connector by pressing the clear button. Quickly insert the tubing into the inline connector of the new chest drain so that you hear a click indicating a good connection, and immediately unclamp the blue patient tube clamp and verify that suction is connected. If you need to collect a sample of fluid, there's a convenient sampling port here. Per policy, clean for 15 seconds. Apply a sterile syringe and get your sample. In the event the chest tube is dislodged from the patient's chest, apply a sterile occlusive dressing and tape it on 3 sides. Do not tape the 4th side to prevent increased lung tension. If a connection is dislodged at any point below the insertion site, place the end of the tubing in 1 to 2 inches of sterile water to reestablish a water seal.
When a patient has a chest tube, be sure to have an occlusive dressing such as petrolatum gauze and gauze pads or drain sponges at the bedside. A transparent dressing to cover the area is also recommended. It's important to remember to have 3 sides sealed, but to leave 1 edge open on the dressing. In summary, let's review some key components of the chest drainage system. The water seal chamber needs to be filled to 2 centimeters at all times. When the chest drainage system is first set up, a water ampule is on the back. It's placed on the port at the top of the chest drainage system and filled to 2 centimeters. Then the ampule is discarded. When suction is ordered, it is connected to the chest drainage system via the port on the top of the system and connected to the wall suction at -80 millimeters of mercury or higher. The visual expansion of the bellows says suction is operating. It's recommended to hang the unit at the bedside using the hangers to avoid accidental knockovers. Continuous bubbling in the water seal confirms a persistent air leak in the patient's chest cavity or tube connections. Intermittent bubbling confirms the presence of an intermittent air leak. When monitoring the system, it's important to periodically check the water seal level. It should be at 2 centimeters at all times. If it's underfilled or overfilled, it can be adjusted via the grommet on the back, where sterile water can be inserted or removed if it's overfilled. In the event of an accidental knockover, upright the drain and check all the fluid levels. If you need to add to sterile water to get to the 2 centimeter mark, you can do so via the grommet. If blood has contaminated the water seal, it may be advisable to replace the chest drain with a new unit. If you notice drainage has gone into other columns in the collection system, you can tip the drainage system to the right as shown and redistribute the fluid collected into the appropriate drainage column. It's important to palpate the area around the chest tube dressing for subcutaneous emphysema, sometimes called crepitus. If it's identified, be sure to mark that area and notify the provider if it expands. If you need to change out the chest tube drainage system because it's full or it's tipped over, you disconnect by clamping the tubing, pressing on the clear button to disconnect, and take the chest tube system that's already been prepared and connect it quickly. You do not want to leave that tube clamped except for a brief period of time. If dislodgement occurs, cover the end of the tube with your gloved hand. Place the dislodged tube in sterile water. Connect to the new drainage system as shown previously. Be sure to document the volume, date, and time on the chest tube drainage system. Disposal of the chest tube system should be done in a biohazard bag. Portions of this educational video were taken from this YouTube video and the Atrium educational site. Please reach out to your educator should you have any additional questions. Thanks for watching.